I'm greeting everyone and welcome everybody. On behalf of the WBMT Nurse Group, in collaboration with your institution, the Lagos University Teaching Hospital, and the Sickle Cell Foundation in Nigeria, I would like to thank you all for participating in another important milestone, which is the BMT Nurse Post-BMT Workshop webinar. The workshop, you remember, that was held last November 23 with your institution was just the beginning of this wonderful collaboration. And it is the WBMT Nurse Group commitment to do the follow-up programs on every undertaking with institutions around the world to help empower nurses in the field of stem cell transplant and cell therapy. The webinar will be done in a series of 8 months or more, depending on the need and demand, and the discussion in the webinar will hopefully reinforce the topics of the last year workshop. The follow-up program in the form of webinar and other educational activities or material will be a template that will be adopted whenever the WBMT reaches out to other countries. We are proud that this template was pioneered in Nigeria. Again, I can tell you we are very honored to welcome everybody. And now I would like to present to you Nouf Mohammed Shwikan. She's a nurse. She's a BMT nurse clinician. She's a pediatric oncology, and she's one of our expert nurse panelists from King Faisal Hospital and Research Center in Jeddah in Saudi. And so she will discuss to us and she will let you know all about sickle cell patient. And please go ahead, Nouf.
Hello, everyone. Good morning and good afternoon for all participants in this wonderful follow-up after our great effort in the WBMT nursing workshop. I would like to share my screen. Okay, so the beginning, I'm going to show you the first slide, which is the topics that we're going to share today, which is, as I mentioned, that we're going to discuss the indication for sickle cell disease, and also the preparation for the patient and donor, and the pain management. Next, please. Okay, as introduction, the next also. As introduction, I would remind you about what is the sickle cell disease. Next slide, please. The sickle cell disease, as you are aware, that it's an inherited genetic abnormality of the hemoglobin. And as you know, the hemoglobin is important cell for carrying on the oxygen, the protein, and that found in red blood cells. However, this abnormality causes stuck in small blood vessels, and which can also slow the blood flow and the oxygen to parts of the body. Normally, the red blood cells are flexible and round, moving easily through your blood vessel. And these blood vessels in sickle cell patients, it's a change the feature of the normal red blood cells. So it will be sticky, it will be rigid, and not easily and not easy to move through the blood stream. So the red blood cells, it can live up to 120 days before the body needs to replace them. Okay, while the sickle cell lasts 10 to 20 days. That cause anemia, that cause and many red blood cells disorder. So the sickle cell anemia, why it's important that we know this information to understand the complication that patients are going through that. So it's affecting many or million around the worldwide. For the sickle cell, the previous slide, please. The sickle cell disease, the sickle cell disease is the most common genetic blood disorder. So it's a genetic condition that occurs when the child receiving the sickle cell trait from each parent. And accordingly, the Center of the Disease Control and the Prevention, sickle cell disease affect about 100,000 people in the United States, and the other statistics I will show it to you right now. This disease particularly common among the from Africa, from South America, Caribbean, Central America, Saudi Arabia, India, and Mediterranean countries. For example, in Saudi Arabia, we have 4.2 of population carries the sickle cell traits, and in the highest prevalence in the Eastern Province, where approximately 17% of the population carries the gene, and 1.2 has sickle cell disease. Why we are discussing these statistics? Because we are aiming and to train the nurses who are gonna take care of those kind of patients during the procedure of the bone marrow transplant. And the bone marrow transplant is the only cure for this sickle cell disease for the time being. But it's not applicable for everyone. Okay. So the sickle cell disease, it's characterized by episodes of acute complication and ongoing chronic organ disease, which has been associated with significant morbidity and premature death. So, in advance in healthcare, along with public health measures, have led to significant reduction in mortality for children with sickle cell disease, at least in developed countries. So still everyone is working on that, and some organizations that internationally working very deep to establish the best of the treatment modalities for those kind of patients. Although BMT remains the only available curative therapy, as I mentioned, for sickle cell disease, it's not all affected individuals are eligible for this such therapy, primarily because of the significant toxicities associated with the procedure. It means by preparation those patients before going to the BMT. It's also the BMT currently indicated in person with severe sickle cell disease with complication including stroke, acute chest syndrome, recurrent pain crisis, neuropathies, retinopathy, osteonecrosis, and multiple joint and paraplegism. So these complications, keep it in your mind. Later on, we're going to discuss. So the decision to proceed for BMT is complex. It's not easy decision. It must include a discussion, potential benefits and risk, such as the infection, graft versus host disease, and organ injury, and from the conditioning regime. The conditioning regime, it's not easy medications that those patients are receiving, because their main disease, it's inherited, and it's about gene. They are receiving treatment similar to those cancer patients. Okay. So we need to consider all the complication of those medications. In addition, BMT can be unpredictable effects on pre-existing heart and lung and kidney disease. Next, please. So Also, in addition, the transplant only indicated when benefits outweigh this risk. Okay. We need to discuss also the severity of sickle cell disease. Those patients are categorized as severe when the person or the affected person requires more hospitalization, for example, 3 or more times per year for the pain crisis. Also has a history of acute chest syndrome. Also has neurological complication such as a stroke, either overseeing or silence. Abnormal transcranial Doppler is really important to discover this complication. Those patients has pulmonary hypertension, and the majority of those patients are on chronic transfusion for control of their symptoms. Okay, next, please. Next. So why we are doing the bone marrow transplant for those patients, for sickle patient. This is an example for the indication that we are doing bone marrow transplant for the sickle. Number one is the HLA identical sibling. So once the patient has sibling and it's identical, they are proceeding to do the transplant. Let's say that it's one major causes for transplanting. Second thing, that those patient has one or more of the following complication. Next, please. Which are the stroke, or they have central nervous system event, like repetitive and more than 24 hours, impaired neuro psychological function with abnormal cerebral MRI. And let's say that those patients, if they have this complication, it doesn't mean once it's happened that we are going to take those patients immediately. No, they need extensive follow-up related to the complication that they have. Okay. Also, this patient has recurrent acute chest syndrome, stage 1 or 2 of sickle cell disease, sickle lung disease, and this is very, I cannot say very rare, but it's one of the causes, but it's rare compared to the other complication. Also, sickle neuropathy with another or with additional symptoms that patients they need to have GFR above 30 to 50%, and as you know, the normal GFR it's above 60%, but this is the indicated values. Also, those patients maybe have abnormal transcranial Doppler, pulmonary hypertension, and silent cerebral infarction. Okay, so we cannot say that we are waiting those patients to be more sick or having more complications, but the indication to do it before the, let's say, the stable sickler patients, it gives them the priority to proceed with the sickle cell, with the bone marrow transplant. Okay, this is an example for the protocol that we are using for allogenic PMT, standard condition protocol in pediatric, and we have for adult, but this is the pediatric, and it's explaining why those patients are going to receive the bone marrow transplant. Okay, next, please. Okay, so what again we're gonna ask why bone marrow transplant? It's not easy procedure. It's not easy procedure. So it's safely allow treatment with high dose chemotherapy or radiation therapy by replacing or rescuing the bone marrow damaged by the treatment. replace bone marrow that's not working properly with a new stem cell and provide a new stem cell. Okay, so in non-malignant disease such as the sickle cell disease or thalassemia, where the causes is dysfunction of hematopoietic cell, the bone marrow transplant procedure to replace the insufficient patient's immune system with donor 1. Okay, more recently, the focus on the quality of life and poor long-term disease outcome has brought the BMT to the frontline therapy for those kind of patients. This is the most important that you know. It's not easy procedure, but it's important. It's like the current treatment for them, and it's giving them better quality of life. Okay. Next, please. Are we okay? Okay. And keep in your mind that some patients will develop more complications based on the current complication prior to bone marrow transplant. We have some patients, they have recurrent infections, absolutely anemia. Some patients, they have episodes of pain, and this is really significant in the recurrent admissions, which is the pain crisis. They are going through the pain crisis or a vaso-occlusive crisis, we call it. Some of them, they are complaining of the jaundice, yellow eyes and skin, heart failure, stroke, and of course, with all of these complications, those patients may be developed organ damage and delay also in their growth, and they have multiple organ failure. Okay, so as we mentioned before, the next please. As we mentioned before, that we need to do this kind. We need to do the. We need to understand the indication why we are going to give the transplant, and what is the benefit of the transplant, how they are getting the benefit. Potentially curative. It's prevent and stop organ damage associated with sickle cell disease. As we mentioned, the normal cells, the abnormal cells, the crescent cells, it's becoming normal. So the function of their organs is becoming more normal. It also avoids those patients iron overload associated with chronic transfusion. And the studies shows that it may also lead to reversal of a neurological damage and recovery of a splenic function. And this is why we need to have extensive investigation and this clearance before going to transplant. Okay. Next, also, it's done if done early, it may improve overall the life expectancy or the quality of the life. So we prefer to do that in early age, in pediatric age, before those patients having more complication. It's actually more cost effective than the standard of care. Okay. Next. Excuse me. Okay. This is an example for the comparison of the transplant for non-malignant disease versus the malignant disorders, similar leukemia and oncology. So those patients are, as you can see in the left column, it's myeloablative conditioning involving high dose of busulfan or TBI, which is a preferred approach. On the other hand, for non-malignant, it's reduced toxicity regimen but even though it's heavy treatment for sickler patient with decreased dose of busulfan, melphalan, and treosulfan. This is in adult mainly. For the GVHD, some degree of GVHD tolerated for to facilitate the graft versus leukemia effect, but in non-malignant, no role for tolerating GVHD aggressive, or the GVHD prevention regimen is advocated. It means that it's really important to prevent the GVHD in non-malignant cases. Also for the chimerism, also in malignancy, the goal is to achieve complete donor chimeric, but in the non, we are stable with mixed donor chimerism associated with the symptoms resolution in many diseases. So it might take time, but it's okay to be acceptable. So curing of sickle cell disease with bone marrow transplant, what is the best? The BMT from matched sibling donor. It means the first sibling from the brothers and sisters or unrelated donor remains the best option for treatment for severe sickle cell disease. Okay. Next. So, are we okay on the timing? Okay. Okay. The second objective that you need to go through it, it's really, yeah, next screen, please. Okay. We're going to talk about the preparation, sickle cell patients and donor and the clearance process for starting the bone marrow transplant. So we have a pre-transplant assessment, which is, as I mentioned, this disease status, blood with virology status, radiology, cardiac, pulmonary, and renal examination must be undertaken. And the result of this, along with a suitable donor, medical clearance, and cell availability, are essential to ascertain the transplant is valid option. Okay, is a valid option. The result of this pre-transplant, next, the result of this pre-transplant assessment will help to inform and adapt the transplant modality, conditioning regime, the type of the graft, the stem cell source, and the post-transplant strategy, which is the immuno modalities and DLI. It might be difficult to adapt with these terminologies, but I need you to make it in your consideration. The pre-assessment, it's not an easy process. It has to be well implemented by multidisciplinary team. It's not only the physician. We need the lab with us. We need the other departments or the other subspecialty, like the infectious disease, the cardiac, cardiovascular, the radiology, and many of multidisciplinary team to assess those patients. It also allows the doctor to detect any abnormalities that could lead for post-transplant complication. Here you can see a simple pathway for sickle cell disease patients during the PMT. Okay, just capture it in your, keep it in your mind and capture it every time that you're receiving sickler patients. What are the phases that the patient going through? Selection of the candidate, as I mentioned, it's who is the patient is fit for this procedure. We cannot take all the patients for this procedure. Donor selection, as I mentioned, the HLA matching. And we said that the best one is the match sibling. or unrelated donor match. Also, the mobilization and harvesting. What does that mean? Mobilization and harvesting. I think in coming sessions we will talk deeply in this terminology. But mobilization and harvesting, it's mainly for the donor. Okay, it's a procedure done for the donors. Okay, mobilizing the patient by giving some medications to elevate the CD34. So those donors will be ready and having good amount of stem cell to be ready for harvesting. Harvesting, it's the collection of the bone marrow, okay, which is mainly bone marrow. Some of the donors will have peripheral collection, and it's also depend on the the donor condition. Okay, insertion of the central line catheter. This is also important for the patient. Then conditioning regime. Conditioning regime, it has to start within a time before day 0 of infusion, or the day of the transplant. So the patients will not receive the treatment and go home, then come back again for the infusion of the stem cell. Once the patient's admitted to the hospital to proceed with the BMT, they need to receive these as a subsequent and followed by the steps. After the conditioning, we have stem cell infusion, or day 0 of infusion. After that, the patient will have, or now we will not call him patient anymore, he will be recipient. He received the stem cell. So the recipient will go through the neutropenic phase, then the engraftment, then the recovery, then the follow-up. Okay. After the engraftment and the recovery, also in coming sessions, we will be in deep discussion and the follow-up as the either inpatient or outpatient. Next slide, please. Here is some important information about the HLA typing or HLA matching. As you can see, how we know that this are matching or not matching. The matching, it's must be performed to identify the suitable donor. The red cell phenotype of the recipient and the donor is obtained by screening from the donor and from the patient, but mainly it's the donor-directed antibodies. Okay, it's undertaken because the risk of pure red blood cells aplasia after the PMT, so it needs to be done before. Okay, so you can see in at the right or the left picture, it's simple picture of very complex process. Okay, when we can say this is matched donor or not matched donor. Okay, next please. So who are the donors that we can take them as the best donors? The transplant workup may vary from center to center and will be dependent on the clinical indication and the center guideline. And I think this we'll discuss it in the quality later on. The transplant coordinator would usually organize and collect the information and the result as well. Okay, so there is it has to be eligibility criteria for the patient and for the donor as well. Okay, we selected the patient, as we mentioned, why we took those patients to the bone marrow transplant procedure. Now, when we selected the donor, what we are going to do with the donor before taking him for harvesting. So next slide, we will discuss that. It's not exclusive, but gives the indication of the workup required prior to the transplant admission. Okay, we cannot start the chemotherapy or the conditioning protocol if there is no clearance. Okay, so the donors will have, this is for the patient themselves, full blood count, bone and liver function profile, virology, transplant assessment. We need to assess the patients for many viruses, hepatitis, HIV, and CMV, EBV. And it's really important for bone marrow transplant nurses to follow up on weekly or monthly basis post-transplant for the CMV and EBV. Okay, and the infectious disease sessions, it's really important to discuss this. So inshallah, by the next sessions, they're gonna discuss the CMV and EBV. But it's really important for nurses to follow up the patients when they are inpatient, and why important to not miss the screening and to not miss the important workup post-transplant. And group and safe sample. Why we are saying a group? So some patients, they might, after the transplant, their blood group might change, so it has to be saved and documented. HLA antibodies is screened. Coagulation profile is really important. Tissue typing, in case the patients needs any screening before the allogenic transplant, they need to do the tissue verification and verification typing. Patients who have been heavily transfused prior the transplant should have serum ferritin level. It's really important to check the serum ferritin. Excuse me. Cardiac function is really important. As we mentioned, those patients, they have many complications. So echo and MOGA scan, it's depends what is preferred based on the condition, but echo is the most important. Healthy individuals typically have left vertical ejection fraction. It's recommended to be between 50 and 65. Just to mention, whoever from those patients have a cardiac issue, they need to be cleared also from cardiac specialty, not from only transplant specialty. Calculated creatinine clearance or EGFR, or to estimate the renal function, because those patients were going to receive highly toxic medications before transplant, so we need to evaluate their kidney renal function. Pulmonary function test. Keep in your minds, those patients has acute chest syndrome, repetitive crisis, so it's very important to have BFT. Bone marrow aspiration, it's depend. This is plus or minus, not definite indication for bone marrow, for sickle cell disease. Okay, a double lumen central line, central venous catheter. Why double lumen? Because with the time you will administer immunosuppressant agents, and these agents, it needs to indicated to have levels for those kind of medications. So you need separate lumen for the central lines, that it's not mixed between the infusion and the sampling lumen. ECG and age-specific clearance. Okay.
No, you pull it back,
please.
Yeah. Back a little. You pull it back.
Okay.
You pull it back.
Excuse me, can you mute? Okay. So we did the workup or the clearance for the patients. Now we're gonna do the clearance for the donor. Okay, after selection, the donor, we need to do some serological test within 30 days prior to the cell harvesting or before collecting the stem cell. Why? We don't want to transplant an, let's say, infected stem cell. So those donors, they should isolate themselves, not in very closed area, but they need to take care of themselves before getting any infections prior to the transplant. Okay. Also, they need some females donors. They need to check also their pregnancy within 7 days prior to harvesting. Also, for the donors, we need to check the virology, CMV, EBV, hepatitis, and other and HIV and other viruses. Urine culture is really important to not have any infection during that phase. BMT and the HLA typing and the resolution. This it has to be coming early, like during the workup and the clearance. Actually, just to make it easy for you, we have here, for example, the BMT coordinators are taking care the patients with a physician and the donors with other transplant physician. So the main physician will not have the donor and the will not do the clearance for both of them. They should be different. This is as per the hospital IBB and most of the international centers. Different transplant physician will do the clearance, one for the patient, one for the donor. Okay. Also pre-chimeric study and ECG or chest X-ray and age-specific clearance for any indication as well. Okay. Next. Yeah, also we have some workup like CBCD, reticulocyte count, type and screen, direct test, coagulation profile, and the rest, the renal, ferritin, ESR, G6PD, hepatic renal, bone profile, random glucose. It's really important during before the transplant process or before the harvest for the donors. Some hormones is important to test if it's indicated. It's mainly with the donors who have past medical history. Also for other, excuse me, I hear noise in the background.
Hello, Blessing, please. There is a lot. Please, yeah. Can you look at the noise, please?
Okay, thank you. So also to go through the serology workup for this is more general serology workup, but as I mentioned, the top priority within the days, like the serology for within 30 days, it has to be obtained. Okay. Next, please. Here we have some consideration for the next slide, please. Yeah. Consideration for the pre and post-transplant period. You can see in the pre-engraftment and pre-HSCT, pre-bone marrow transplant and post-infusion, but post-infusion, but before the engraftment, and also post-infusion, post-engraftment. So why it's critical? Critical for the RBC's transfusion, transfusion before the stem cell infusion. It's mainly targeting the hemoglobin S. We need to maintain it below 30%. Also, we don't need any iron toxicity overload during the conditioning. Some physician indicating or requesting to have RBCs exchange transfusion at least once before the transplant. Also looking to the recipient HLA antibodies and the depletion for the RBCs. I think this schedule can be explained more in next sessions, inshallah. Now the time is not saving us, so I'm going through the last goal for this, or the last objective of this presentation, which we're going to talk about the pain management or the pain crisis in the sickle cell disease. Okay. As we mentioned, it's the condition of very common disease. The associated, just no need, I mentioned this part, the cost associated with healthcare for sickle cell population exceeded $1 billion yearly. So, and the majority of the cost is associated with the admissions related to the vaso-occlusive events. So, the complication, which is the mainly the vaso-occlusive crisis, is costly effective. Before discussing more in pain management, we need to define some terminology. We need to understand what is the pain. Okay, we know the pain is the, as a nurses community, we know the pain is the fifth vital sign. So it's unpleasant and unpleasant sensory and emotional experience associated with actual or potential tissue damage, or described in terms of such damage. So those patients will not experience normal feeling or fatigue or whatever. No, it's a huge pain and it's severe pain. We need to do also the pain assessment. So what is the pain assessment? Okay. Many nurses are having very limited information about pain assessment, but especially for sickle cell disease, we need to gain more knowledge about how to assess those patients. So it's an ongoing, complete systemic process of identifying the pain severity. We need to identify the pain severity, the location, and its characteristic, including the response to the treatment for pain. Okay, and how this pain is alleviated. Also, we need to understand the pain management. What are the interventions intended to prevent or alleviate or eliminate the pain and maximize the patient functioning. Okay, you need to provide the comfort for those patients before going to administer anything else. Also, we need to identify the patient type. Pediatric, they are not like adult. Some patients are able to communicate with them. Some patients, they have difficulties, or they are more vulnerable patients. So we need to understand the communicative patients who are able to provide self-reports. They are saying to you that I have pain. Other non-communicative patients, they are unable to provide the self-report verbally or physically. Okay, next, please. So every time we have patient with pain, sickle cell disease patient with pain, we need to go deeply with this information. Types of pain, we have acute, as you know, and chronic. The acute, it's a brief physical cause, usually known. The pain subsided as healing takes place. Intensity can range from mild to severe, associated with tissue damage, inflammation, or Inflammation, surgical procedure, brief disease, the procedure. Acute pain episodes may be present in a patient with a chronic pain. Okay, so some patients with a chronic pain, they might have episodes of acute pain. Now we need to know what is the chronic pain, which is malignant or non-malignant pain that exists beyond the expected time frame for healing, or where the healing may not have occurred. Chronic pain worsening and intensifies over time and persists for months, years, or a lifetime. It accompanies the disease process such as cancer, arthritis, fibromyalgia, diabetes, or injuries. And also, I need to mention this: it might happen. It's happening with the palliative patients who are in the last or end of life stage. It can be subdivided to neuropathic or nociceptive pain. So, what do you think in most of sickle cell patients? Absolutely, they have in between, depend on their condition. In early ages, or those teenagers, they have more likely this acute pain, and they have intermittent admissions. But you might find adult patients, they are already in chronic pain, and in between they have the acute pain. Next slide, please. Okay. How this pain is coming to those patients, or it might be, what are the locations that most commonly having the pain? It's the bone or the limb, like osteomyelitis, vascular necrosis, cellulitis. Okay, these the feature that it's coming with the sickler patient. It might come an abdominal pain, but it's reflecting more differential diagnosis. So this patient, they might have cholecystitis, appendicitis, bowel obstruction in some cases, but it doesn't mean that absolutely it's cholecystitis or appendicitis. So we need to know the location. That's why I mentioned before the assessment, the pain assessment, and the location and the intensity. Okay. Also, in a growing area, mainly it can happen as testicular Trojan and renal colic. Back pain, most of them, they have back pain, but it's reflecting the aortic dissection, the disc herniation, and this you find it more in adult than pediatric. Okay. Headache, either it's absolutely coming with the patients with a stroke, okay, or retinopathy, but mainly with a stroke. Just to highlight for you, these pain types of pain, it's really important even to predict it post-transplant. Okay, not only before transplant, before, during the conditioning, and post-transplant. Okay. Also, chest pain, the most common is acute chest syndrome, or MI, or pneumonia, pleural effusion, and etc. Okay. So the differential diagnosis for sickler vaso-occlusive crisis, the patients have increased suspectability to certain disease pathology that should be considered depending on the pain type and location. Next. Just to mention here for you that we're following here the guideline for the ASH, for the clinical practice guideline for sickle cell disease, to identify the pain and what are the approaches to treat the chronic and acute pain for sickle cell disease. Briefly, it's a clinical treating individual for sickle cell disease, including the medications. Not only, we cannot say only morphine, it's most common, but it says here many approaches for the pain management. One of them, or including the massage, the yoga, virtual reality, and guided audio-visual relaxation. This is just an additional. Later on, we will go through the medications, but just to mention this for you, that we need to consider beyond approach beyond the known treatment. Okay. Next, what are the symptoms? We mentioned the pain and the location. Now, I would like to share this with you. The symptoms of the sickle cell anemia usually appears around 6 months of the age. Okay, this is most likely in the infant and then pediatric. It's vary from patient to patient and may change over the time. But these symptoms, episodes of pain, extreme pain called pain crisis. It's developed when the sickle cell, sorry, I need to skip this part, but some patients with sickle cell anemia have also chronic pain from the bone and joint damage, ulcer, and other causes, swelling in the hands and the feet, frequent infections, delayed growth or puberty, vision problems. These are the most common 6 complications you will find it in the patients. Okay, this is how it's coming. Okay, because later on we will know about the urgent or the active treatment for them. The goal of the treatment are the symptoms control and management of the disease complication. Why we are treating that? We need to manage the vaso-occlusive crisis, the pain controlling the pain, the chronic pain, chronic hemolytic anemia as well, prevent and treatment the infection, manage the complication and various organ damage, prevent the stroke, detection and treatment of pulmonary hypertension. Okay, so once you treat the pain, it doesn't mean only the pain. You are managing a lot of things with the pain. Okay, next. So as a nurse, what you need to do? Now you have background why it's really important to do the pain assessment. You need to provide the treatment based on the doctor's assessment and orders, reassessment, and adjustment. What is the difference between these 4 stages? In the assessment, this is the initial assessment or initial scoring that you are giving the patient. Then you provide the treatment. After the treatment, what's happening to the patient? What is happening? Are they responding or not responding? So in reassessment, you will re-evaluate them, and it's depend on your protocols. Some medications needs to be reassessed within 30 minutes, and some needs after 1 hour. The most likely the IV medication needs to be reassessed after 30 minutes. So then from 45 to 1 hour, the oral medication. Then the adjustment. What's the adjustment mean? You need to adjust if the patient needs this dose or need more additional medications to alleviate the pain. So is only the nurse will do this assessment. It's multidisciplinary as well. It's between the nurse and the physician, and in some centers there is the pain management team. So you need to consider all of these teamwork. So considering the severity of the pain and the patient in past response, this is when I mean the reassessment. Follow the consistent protocol to relieve the patient's pain. Okay. Next, please. Okay. Also, it's mentioned in the ASH. This is for, you can skip this part. I can explain it. Just go to the medication summary. Next. Okay. Next also. Next. Yes, this one. Thank you. Just to summarize the protocol, it's at the beginning it will be difficult for you to go through the protocols, but within the time with the assessment of the patients, it's really easy, inshallah. So in children and adult patients who are looking for the treatment of acute pain, should standardize the protocol to be used that including or reduced the first time. So upon arrival to the ER or emergency, they need to be evaluated. We cannot ignore their pain. They need to be evaluated, and we need to administer the medications within 1 hour or less than 1 hour. In addition, more frequent. So their assessment has to be, we cannot say, no, we'll go to do the other assessment like the X-ray or the lab or whatever. No, the pain medications, it has to be administered less than 1 hour or 30 minutes. Then observe the patient for tolerating the doses. In the previous slide, well, yeah. The medications, what are the medications that patients are previous slide, please, Roman. The goal of the pharmacology are to reduce or prevent the complication, not only the pain. The drugs used in treatment for sickle cell disease, including many medications. It's depend also on your center. What are the medication it's given for the sickle cell patients? Some of that are anti-myopilin, which is considered as a chemotherapy, like the hydroxyurea. Some are analgesia. This is what for us, this is what most common that we know. But some medications are metabolite and antibiotic and some nutritional agents. For example, we'll go through it. Like the most common is the hydroxyurea or Vexillotor. The opioid analgesia, it's not only the morphine, but the most common is the morphine. So those patients going through the protocol, they might use single or double agents. It's depend on the pain severity and the frequency as well. Methadone can be used, morphine sulfate, acetaminophen, fentanyl, codeine with acetaminophen, which is the Tylenol, and the non-steroidal analgesia like aspirin and acetaminophen. Folic acid can be used, and antibiotics for the infections or recurrent infections with the patients. So this is the most common medication can be used for sickle cell patients. But are we going to use it all? No, we need to know the history of the patients. We need to know the response and how this patient, how the pain is alleviated. Many patients are having different response from one to other one, but just the most important thing is we need to administer this medication on safely manner to avoid the addiction of those patients. Okay, because why I need to mention that in some sickler patients, even in younger age, if the treatment was not followed up very closely, the pain, the pain management prior the BMT. During the BMT, those patients might have repetitive infection, repetitive crisis. Even the pain, it might not be well managed. So going through the protocols is really important and so efficient to control the pain. Okay. The last slide, please. Just to mention to you that the sickle cell disease treatment and management, the approach continuous infused morphine is most effective, attempting to resolve the pain by providing 1 to 2 doses of the perinatal narcotics in the emergency department is inadvisable, since moderately severe sickle cell pain is expected to persist for several days. So some physicians are not recommending that morphine is the best solution upon emergency. We need to give them the treatment, but this will turn them to be addictive for the morphine. For the past few years, we really have good management due to the well-established protocols for the sickler patients. Okay, thank you for listening. And just to remind you that as a BMT nurses, what you need to do, it's not only do the assessment and give the medications all the time, ask, assess, access patient information, appraise, reevaluate, apply the evidence-based practice, and share it with your team. So communication with both nursing colleagues, physicians, and ensuring excellent medical care for those patients, giving them the useful and clear information to the whole team. Thank you so much.